Hello, JACC. I'm Emile Daoud. I'm here with Michael Lim and Peter Kistler to talk about their very important study looking at posterior wall ablation and the outcomes following that. Michael, can you tell us a little bit about the study?
So, in short, essentially, we looked at our study population included all AF ablation procedures done at 4 high-volume centres in Melbourne, Australia, over a 14-year study period. Ended up being about 4,700 plus patients included. And then we looked at the incidence of atypical left atrial flutter, flutters requiring procedures, and according to the ablation set performed at their AF ablation. I think the key finding was essentially that there was a clear dose-response relationship between the extent of left atrial ablation and the incidence of left atrial flutter. So in the PVI-only group, it sat around about 3%. It doubled with the addition of posterior wall isolation to PVI, and then doubled again with additional left atrial ablation in addition to PVI and posterior wall isolation.
So, interesting finding, something that we've kind of seen a little bit of a signal from other studies, but not as conclusive as this does with the large numbers and patients in many years. Peter, so the question to you now is, okay, we have more compelling evidence, which you also worked on with posterior wall isolation, kind of getting another chink in the armor for that strategy. And now you're teaching us about these left atrial macro-reentrant tachycardias. What's the take-home message in terms of, when you're ablating AFib for, let's focus on the persistent AFib population. We'll say for paroxysmal PVI, but let's say for persistent AFib. What's your thought on all that?
Well, I think after we completed the Kistler study, which showed no benefit in adding posterior wall isolation using RF to PVI alone in persistent AF, our general approach in patients with continuous AF of less than 12 months duration is PVI alone. This data just expands the concept that the more ablation you do, the more vulnerable you'll leave a patient to atrial flutter. Although the increase in the incidence of flutter only went from 3% with PVI alone to 6% with PVI and posterior wall isolation, it doesn't justify then doing a prophylactic mitral line, which was one of the things I observed when I was designing the Kistler trial, was that the previous studies would often empirically include a mitral line, presumably because the operators were concerned about the risk of perimitral flutter. And in some ways, this data is reassuring in that the incidence of perimitral flutter was actually less than 5%. So, if you are going to do a posterior wall, do not feel compelled to include the mitral line. And in fact, particularly with RF, we know that you're at risk of gap-related re-entry, and you're probably only going to increase the incidence of perimitral flutter with a prophylactic mitral line. Okay,
so just among us here, you're doing a persistent AFib next week. What will be your an index procedure? What will be your lesion set?
Cardioversion, PVI only.
Okay, and then they come back with a left atrial flutter, and we'll say you're going to do PVI on the second procedure and make sure that the veins are isolated. Yep. You map the flutter, you get that, it's a gap flutter, something like that. Do you do anything else empirically on the second procedure?
So I'll map the flutter, ablate whatever needs to be done for that flutter, and then I'll do a voltage map. And in that situation, firstly, if it's a perimitral flutter, we'll do a voltage map to determine whether we'll do an anterior versus a lateral line. So if there's a large area of low voltage or scar in the anterior wall, then we'll select an anterior line. Otherwise, we would do a lateral line.
Great stuff. I'm going to ask you one other opinion. So there's a lot of computerized AF mapping systems out there. Do you think they have any role, since these kind of one strategy for all doesn't seem to fit? What do you think?
Well, I think we all would prefer a concept of tailoring our ablation strategy to the patient's substrate. But I haven't yet seen a system that's delivering that. But I'm certainly very hopeful, and that's also where I'm hoping AI comes into it as well.
There it is. Some great insights from a great center. Thank you very much.
Thank you.